Everyone, thank you for coming. This is the final lecture in the Lefebvre Winter Series on aging for 2015. So, I'm delighted to introduce Dr. Tracy Harrison. Dr. Harrison is an associate professor in the School of Nursing at UT Austin, and she's a member of a vanishing breed among academics. She's a person who is an academic, has academic excellence in the triumvirate of teaching, research, and clinical service. And there aren't very many people in academia that have that level of excellence in those three. It used to be more common. We've become more specialized, and people have their areas of excellence in research or teaching or in clinical service. There's relatively few of us who have expertise across the board. And I don't consider myself one of those people, but Dr. Harrison clearly is. She received her baccalaureate degree in nursing from UT Austin, and then went to Texas A&M at Corpus Christi to complete a Master of Science degree in nursing, and then back to UT Austin, where she obtained her PhD also in nursing. Dr. Harrison completed a postdoctoral fellowship in gerontological nursing at UT and joined the School of Nursing in 2004. Dr. Harrison's research has focused on aging and disabilities, specifically the intersection between age-related change and functional impairment, and how this intersection affects social role performance and health outcomes in women. Her research uses interview methods to collect data on how women perceive their aging experiences. And her research has been supported by a variety of sources. She is currently a PI on a Texas Department of Aging and Disability Services grant examining quality indicators in nursing homes, and recently completed an R01 grant from the NIH studying health disparities among Mexican American women with disabilities. Her research has been published in a wide range of journals in nursing, aging, geriatrics, health policy, and disability studies. She has served on editorial boards, federal grant review panels, and received numerous awards for her research. In 2004, Dr. Harrison was elected a fellow in the prestigious American Academy of Nursing. Dr. Harrison is also an active and respected educator. She's involved in teaching and mentoring students at a variety of levels, from undergraduate to doctoral. From 2010 to 2014, she served as a chair of 4 dissertation committees and as a committee member for another 10 graduate committees. Many of her publications over the past 10 years have included students and trainees at various levels of education. Dr. Harrison's clinical expertise and experience are reflected in the fact that, in addition to her status as a registered nurse, she completed certification in advanced cardiac life support, certification as a critical care registered nurse, certification as a family nurse practitioner, and is a licensed advanced practice nurse. Please join me in welcoming Dr. Harrison to UTMB as our final Lefebvre Winter Series on Aging speaker for 2015.
Thank you, Dr. Altenbacher. That was incredibly nice of you. I appreciate all of those things. I would like to speak to you today about the meaning of aging with disabilities, but more specifically about what it means to think about going into a nursing home as you are aging with a disability. So many of us, myself included, have a disability, but frequently we don't know exactly what that trajectory is going to mean for us. And sometimes we contemplate where we're going to be, say in another 10, 15 years. And that's basically the point of the study that I'm going to present to you today, is what those thoughts were for Latinas as they were aging with their disabilities and thinking about nursing homes, and whether or not that was a consideration, and what those past experiences with nursing homes meant for their future. So let's get started. So we know that there are a considerable number of Latinas with disabilities. And we know that when we look at Latinas with disabilities, they have a different trajectory than other women with disabilities, say non-Hispanic white women, African American women. So basically there are disparities in the way those trajectories work out, if we want to think of it that way. But mainly just think that there are differences. Now, I do research in Texas with Texas populations, and I was specifically looking at non-Hispanic white women and Mexican American women in Texas. I'm a native Texan. I've been here all my life, and I'm a 7th generation Texan. So the people in Texas mean a lot to me. And right now, we have a growing population of seniors in Texas, and our fastest growing population is over 85. And when I look at the diversity of our seniors, I realize that that diversity is changing that demographic of who is the largest proportion of seniors that we have, and what that's going to mean for our system over time is huge. In fact, there's going to be a 5-fold increase in Hispanics and a 7-fold increase in other categories in Texas over the next 20 to 30 years. So the way we come to understand different groups and how they experience aging needs to reflect what's going on in society. We in Texas, in fact, need to realize what our own population comes to expect from the aging system. So I also know that there is a growing level of disability. When you have a lengthening of lifespan, the chances are you're going to have a growing number of people with disabilities. And that's what we've seen in Texas. But at the same time, we're not doing as well in our aging populations as they are in other states, in that our life expectancy is lower than the national average, and we have higher rates of many conditions. So there are areas that we can improve on. And there are really a lot of reasons as to why we have some problems in Texas. 30% or 77 of the counties that we have are considered metropolitan. That means there's a whole lot of non-metropolitan counties, and 15% of our counties are remaining in persistent poverty. So we realize that poverty, rurality, multiculturalism, lack of access to care, some lifestyle issues all account for some of the disparities that we're seeing in health outcomes in Texas and the high rate of disability that we're seeing. So overall, we're seeing this demographic shift in Texas where we're seeing a lot more diverse populations, especially Hispanics, and we're seeing a lot more poverty, and we're seeing a lot more overall difficulties with living situations, and we're not real clear exactly how it is that we're going to take care of people as we get a larger and larger number of people in the coming years. So I've been working a lot with the Department of Aging and Disability Services to understand what the expectations are from people who have disabilities and they're living in Texas counties, and what we can do to support them in the communities, not necessarily just in the nursing home. So this data comes from my ethnographic study that was an R01 that was funded by NINR, where I looked at accommodations, personal care help, views on what it was to live in the community and what type of things that you needed in order to remain in the community. And I took various views on disparities that you could think about. You know, is it just resource distributions that are causing some difficulties for my Mexican American women? Are they at elevated risk? Is there differences in meaning of things? And then trying to figure out how time and resource distribution and risk all came together in the aging experience. Studies have suggested a difference in awareness and acceptance of different types of assistive technology and accommodations when it comes to Mexican American women. And my team and I, this was my project director, coordinator person, Nora Lopez, and one of my students, Janice Walker, who I'm now very proud to say is a postdoc at Johns Hopkins and doing very well. We're very committed to traveling all over the state and finding out everything we could about Mexican American women living in various regions. So we went to, I guess I drove to 44 different counties that were non-adjacent throughout the state over 4 years. And Nora tracked where I was going, and Janice listened to all the interviews and made sure they were typed correctly. So it was a lot of fun. What I'm going to tell you now is the first part of this, because it was mixed methods, and what I had to do was take reality and put it into a questionnaire, which we know the questionnaires aren't really reality. The interviews are one kind of reflection of reality in which I see pretty close what's going on as I'm there in their lives, I'm talking to them, I'm getting a full picture. But I wanted to create a questionnaire on assistive technology. And so it's kind of like these pictures. This picture over here, thank you though. This picture here is a purebred Great Pyrenees. Very lovely. In its natural environment. This one is a fake. He is what my son calls a cur dog. He is kind of a mixed breed. But how do you know that what you've got here isn't here and here there? And so what I'm kind of getting at is they look very similar, but are you really measuring what it is that you want to measure? And so I went through a lot of different processes to make sure that I was actually getting to that pure breed, because my dog's a nice reflection of a pure breed. Just didn't cost anything. So I had in my samples, when I did my interviews, 60 Mexican American women, 62 non-Hispanic white women, all between 55 to 75, all with mobility impairment, and all residing within the community. And I was looking to understand these differences in trajectories, and right now I'm looking to develop that questionnaire on accommodations and assistive technology. My samples, when I looked at the two, were completely similar. Age, BMI, age of menopause, except employment was different. My non-Hispanic white women stayed employed longer. The age of work, my Mexican American women started at as low of age as 5. The years of education were different in that my non-Hispanic white women were significantly more educated. And 13 of my Mexican American women did not speak English. But other than that, those are big things. They were very similar. And I did all of these qualitative interviews in their home for 1 to 4 hours each, getting to understand what it was they were going through with the disability, how they accommodated them, what they wanted as they aged. I did life history calendars, plotting out for each and every woman exactly when impairments came on, when they stopped, defined as any type of illness that had a doctor's diagnosis. I plotted every time they had a functional limitation that caused them to have difficulty in movement, when they came on, when they stopped. or if they continued until the present date. And I plotted out any time they had any disruptions in social role performance, such as they couldn't go to work anymore, they had to hire someone to help them with parenting or some kind of issue that they felt was a disability. So we did the life history calendars. And then I statistically kind of questionnaire measured these types of things: impairment, functional impairment, and then disability, with a survey, so that when I talk to people who do quantitative research and like to measure things, I could say this is how impaired they were, this is how disabled they were, all of those things. And I also measured their depression, their pain levels, and their activity effort. So, now I can tell you, that their level of impairment, my non-Hispanic white women were, when you look at that, had more illnesses. There were more physical conditions like diabetes, all of those types of impairments that interfered with their health. The level of function was no different, though, in the two groups. It didn't seem to change that. And when I looked, though, at level of disability, the women who were Mexican American had more social role performance problems. They were more disabled. And there's a reason I'm going through all of this. I also did, like I said, the results on the life history calendar. And I found that although you can see that the level of impairment is greater in your non-Hispanic white women, it's also, they have a greater percent of their life with an impairment. So when I plotted it out on the life history calendar, they didn't both get illnesses at the same time. The non-Hispanic white women got them earlier in life and were living with them longer. But you can see also that when they look at the age of onset of a chronic illness from their own perspective, there was no significant difference, which is interesting to me. When I looked at level of function, the non-Hispanic white women here had significantly more functional limitation, to go as far as the percent of their life that they had a functional limitation, higher levels than my Mexican American women. When I go back to disability, though, again, whether I was measuring it with the life history calendar, my non-Hispanic white women, again, had more disability in their life stories than did the Mexican American women when we measured it with the questionnaire. So when women were describing their lives, here you see that the non-Hispanic white women were having greater levels of problem. So I also analyzed their stories, their interview stories that they told me when I would talk to them about disability and function and impairment in their homes. And I did a domain analysis, and I found quotes on accommodation use, and there were about over 1,000 of those. And I analyzed those separately for same types of accommodations and made comparisons using Spradley's techniques. And I created a scale that I told you I was trying to look at whether or not I could get close to the reality of my interviews. And it measured psychological impact with questions like, I agree with this particular statement. I believe my assistive device is just part of who I am. So this is kind of, is it part of your identity or not? Or is it something foreign to you? social impact. Strangers do not speak to me when I use my assistive device. So some of the women had thought that when they used crutches or a cane or their wheelchair that people acted like they didn't see them anymore. Device management. I can't get things done when I use an assistive device, and I can kind of relate to this. It's hard to manage it all sometimes when you're trying to move things. And then there's disease management. My assistive device helps me manage unwanted symptoms like pain or fatigue. Well, some women agreed very strongly with this, that an assistive device helped them prolong their activities during the day, but there were women who felt like an assistive device, it really just made pain worse, say an AFO, or something that you thought would have been helpful really wasn't from their experience. So these were categories of items that I used. There were a lot of items that I first generated, and I went back to the women to see what they thought. And we had translated it into Spanish, so we did Spanish and English versions. And we had them either complete it in person, going back to their homes, or we had them do it over the phone. And analyze that along with our measures of disability, function, impairment, pain, and depression. And this basically is a small slide, and I apologize for that. But I'm just trying to get at that all of my measures were reliable and valid. I didn't have anything below, I think 79 as far as a Crombax Alpha. So as far as use of assistive technology, 79% or 96 women owned at least one type of mobility device, and 75% of the Mexican American women did, and 82% of my non-Hispanic women, and these were some of the things that they used. And you can see that all of these women, though, had a mobility problem. They could not walk up steps. They could not walk for a quarter of a mile, like around not a racetrack, but a football track. They could not stand for 20 minutes, or they could not bend from a standing position. So they had these, but not all of the women actually used any type of assistance. So this is actually fairly intuitive slide, so I won't take too much time with it, but you can see these are the normal things that you frequently see with people with mobility impairments. The cane, walker, wheelchair, braces, and then the less common ones you see never used and doesn't own. And you can see really that my two groups of women were very similar. And then my scale itself, these are some of the items that ended up coming through, so I'll let y'all look at those. If I start to use an assistive device, my physical condition will worsen, so that was in the health domain. Disease management. I'm unattractive when I use it. I do not like my friends to see me, more of the psychological domain. So I did a PCA with Baramax rotation. Scree plot showed my 4 components just like I thought. All of my assumptions were met. I did eliminate 4 items to get a Cromback Alpha of 0.83 for these 24 items. And I was very pleased with my results. And I ended up with these 4 subscales. Okay, so how did these things come out? Okay, so I can tell you that when you look at this, it does come out some interesting relationships in that the total score is associated with function, pain, depression, age of onset, years of education. And if you just look at how they manage that device and whether they think it helps them, you can see that these things are very significant. The psychological management and that identity, less with social stigma, like I don't like my friends to see me with it, doesn't really predict as much except for disability and pain. Pain and depression. I'm looking at it funny. And then assistive technology, when you look at disease management, it's associated with function, age of onset, and years of education. And there are ethnic differences here in that the non-Hispanic white women had a better attitude towards using assistive technology, or a more positive attitude about it. My Mexican American women, they were the ones more likely to walk along the walls and hold on to things rather than use something. And the reason I'm giving you this is because it has implications for what these women might want as they get a further down that trajectory of decline. So, I know that my Mexican American women have a sharp decline after onset. So they're not the ones that are living with a chronic illness for years and years, for many years. They get the illness, they're more likely to have a functional limitation sooner afterwards, and they're more likely to drop out of the workforce right after that. So when I was plotting it out, that's what I could see. Where my non-Hispanic white women are those who live with a chronic illness for a longer period of time. They would have functional limitations and still go to work, and then they would maintain social roles as well. But what did this mean as far as the interviews? Basically, I will tell you. It really meant that the women who were Mexican American had a view of disability as not a bigger problem than my non-Hispanic white women did. It was actually fairly similar. They just didn't want to use the same accommodations. It's just that the non-Hispanic white women had been more educated. They were in jobs that had things like time off sharing. They had things like sick time. They had jobs that you could take time off from and then come back to. FMLA, they knew what that was. All of these kinds of things that allow you to stay in the workforce a lot longer. So the Mexican American women, they would drop from the workforce, take care of their children's children, things of that nature. But what happens to them over time was my next question, and probably why some of you are here today by the name of my title of my presentation, is then how did they view nursing homes? Is that where they were headed? If we can't accommodate it with technology as often, if they don't like it as much, if they're having these steep trajectories down, where are we going to put them? What are we going to do? Is the family home where they're all going to be? And I would say no, not all of them, and we'll talk about that a little bit more as we progress. So this was actually a picture I took at, sometimes my mother would accompany me as I drove around Texas countryside. And we went to eat at this little steakhouse, and this was hanging there over the ladies' restroom. And of course, I had to take pictures, so I did as I entered the ladies' room. There were many comments that we took about the nursing home. There were over 1,700 comments on nursing homes by the Mexican American women. And I had a student work with me on analyzing the content of them because I didn't want to be accused of being one way or the other in relation to views on nursing homes. So we definitely saw it in various ways. And this particular student was an aide in a nursing home at that time. So when we analyzed the data, we made sure that we both agreed on it before we made any final placement for thematic analysis. So the first category that we had from the meaning of the nursing homes is there were some positive comments when someone else needs it. So when someone else needs it, you can have a justification, a revelation about it, and maybe have a little bit of dissonance about it, but it can be positive when it's not about you. Like a hotel, it never smells bad either. So this was a comment that was considered positive about a nursing home when her sister-in-law was placed in one. Another one is coming around to it when someone else needs it. So coming around to it means, well, you kind of, as the quote demonstrates, well, of course she was upset with us at first, that first week, but then after that she was all right. Yeah, she liked it. So if it's somebody else, even if you had made a statement in your lifetime that you were against it, you could come around to it over time if it's somebody else. None of the women, when they were talking about themselves going to a nursing home, came around to saying it's not so bad. Okay. Now, when the women were referring to themselves, they did make some neutral comments. The neutral comments were things like, if it makes it easier on you. Sometimes I tell my daughter that maybe I'm better off in a nursing home. And in this particular comment, the 70-year-old was saying that she sees how much work her daughter has to do, and with the children and then her there, maybe it would be better off if she went. So when the women were referring to themselves, they also brought up stories about misconduct, misbehavior, and downright abuse. Quote, there are some people that ignore you, they're too busy, or they don't want to do it. And then we took him to the doctor, and he told the doctor that one of the aides had been abusing him, and he showed him the bruises. So they had stories of people just not doing what they should do in nursing homes to take care of people. And then they had stories of people being really hurt and there being a problem. Then there was, you'll end up dead if you go to the nursing home, when they were referring to themselves. So they put her in a nursing home and she was never the same. There were comments about they put him there for a month and then he was dead. He was gone. And then it's kind of this, you decide. I'm just saying, so it's kind of this, I'm not going to make the interpretation, but let me just tell you this kind of comment. She was in her scooter forever and ever. Right now, she is in a nursing home. So in this comment, the lady was suggesting that the woman, her friend, should not have let her family know that she was having difficulties at home, because the woman had been in a scooter, in a wheelchair forever and ever, but once she let her family in on some of the problems, she went to a nursing home. So it was kind of a forewarning. And then they talked about them as in that line of their family members then making threats to them. So they knew that there could be some consequences that they needed to be kept in line. My brother said, don't lay down in bed all day long because you're going to end up in a nursing home. And for myself, I can relate to that because, sometimes you'll say, you better, you want someone to take care of themselves, and so you want to motivate them and you want to get them moving, but you don't realize that from these ladies' perspective, they're taking it as a threat, that if you don't do this, you're going to a nursing home. So in line of these two last comments, it's careful not to admit changes to your family or to the wrong person. And then here, I'm not joking, direct comments about their expectations not to go to a nursing home. These are when people say, they take a pause and they say, I want to be serious for a moment. I don't want there to be any misunderstanding here. I'm not going to a nursing home. And that's talking about me. I don't care about this person over here or how great it is or the tour we went down. I am not going. So these are the I'm not joking, I'm being very clear here comments. And then there were comments on saying that as a culture, we don't do this. It's not our way. I took care of my mom for 20 years and we never put her in a nursing home. My mom was blind, so I took care of her. So these are comments that this is the way we do it. We do not treat our parents, our family this way. And again, comments such as these that they pity those without Hispanic culture. They pity those who don't have what they need in order to stay out of the nursing home. Don't have a husband or daughter, or who don't have sons to take care of them. How do they manage? They probably go into a nursing home, right? As though that is the worst alternative that could happen to them. And it can be the price you pay then for bad behavior, such as she's a thin lady, never took care of her medication, of her diabetes, and she's paying the consequence. So paying the consequence of something could also be that you didn't do well raising your children. Your children left you, and now you're going to a nursing home. You weren't good to your family, you didn't live up to the responsibilities you had, you will go to a nursing home, and that's the consequence of that. So I'm going to tell you a little bit about two cases, Maria and Agatha, and tell you what happened to them, because in the course of doing this study, we had people who were placed in nursing homes. So this particular case, you see a negative trajectory. I thought it would be a positive nursing home experience at first. We followed her from admission because we knew her before the nursing home placement, and we followed her 6 months afterwards. When she described her life, she said, I got married, it was bad with my husband, I had 2 children, and I worked. I worked doing laundry and ironing. That was my work, washing, ironing, that was my trade in the house and outside. But I tell you, I was left an orphan very young. I was never happy. All my life has been bitter. I never had affection. That was me, sweetie. So she was 73 years old, Spanish speaking. So then she had this fall. I was going to the bathroom, and I think I got tangled up with my own slippers, and then I wasn't able to get to the bathroom. I fell there, and from there I couldn't get up. Here in my hip, I had an operation up here. The ambulance came because a friend of mine called for it, and from there she went to the nursing home. Well, she comes to change me in a bad mood when she wants to. I just finished changing you right now. I tell her, but I'm wallowing in, I am all and she takes her time to come change me. The other day I asked for a pain pill, and a lady came and brought it. Oh, my dear. But suddenly I felt that my stomach turned over, and I started to vomit and vomit and vomit, and I had to grab the trash can there, and no one came. So this was her nursing home experience after her fall. I tell you again that since I don't have anyone who comes to visit me, and I don't have appropriate clothing to be over there, referring to some of the residents that are able to sit in the day room, that she's treated differently, that they don't come and change her, they don't assist her, and since she has no family to come and talk to her in the nursing home or advocate for her, no one really cares. So in the end, Maria's experience was not a good one. She did have children that lived nearby, but she blamed herself for not being a good mom, didn't want to be a burden, went to the nursing home, and felt very much neglected. Now, another experience with nursing home placements that I had was Agatha. She was 60 years old. She had depression. And Agatha, I had met in her home, and her husband was there, and we sat at her table, and she told me she was very sad that a friend of hers who would visit her, a gentleman, had passed away. And she couldn't get past that, she said, and she was having difficulties relating to her family. And then I came again a month later, and she met me in the yard as I pulled up, and she tapped on my window and said, "Take me away. Take me to the park. Take me anywhere." I'm thinking, am I supposed to do that? So my IRB approval for that. And then she showed me the park, and so we went down to the park, and we sat under the trees and talked for the rest of the afternoon, and then I took her home. And she was concerned. She was concerned that her family didn't relate to her, that they looked at her like she was a stranger, that her son was telling her that he didn't like the way she was spending money. Then I came again, and they had taken away her credit cards, so she couldn't spend her money. Her questionnaires were all filled out by her. They were all fine. I didn't have any reason to believe that she had any compensation, any forgetfulness, nothing. But by the time for the fourth interview, she had been placed in the nursing home, and it was due to dementia. And in the nursing home, her family did not want her to be visited anymore. So I wasn't able to talk to her anymore, but her friends were very concerned and contacted me as well, and were concerned that she had just made a mistake and that she didn't have a daughter. So the women overall had a struggle for validation, and frequently they were dropping out of the workforce. As you can see here, the family at times was the social area that meant the most to them, not the work environment. And work became a whole different thing to them than it was to the non-Hispanic white women. And so when the family itself tended to break down, nursing home was the threat. It began to symbolize to them the negativity of a life that wasn't well lived in the face of a disability. They really felt, instead of seeing the body as something that should be taken care of, it had to work. The body had to work and the mind had to work, or you were at risk. And they didn't know when it was that they had a voice in saying that they didn't want to go to a nursing home or did want to go to a nursing home with their families. And they didn't necessarily know how to best use assistive technologies and all the kinds of things that could have helped them live a longer life outside of a nursing home in the context of a family that maybe provided less support or wasn't there. So one of the things that I noticed in doing this work is that this main issue, the expression of Hispanic culture for women, is unique from men, in that I did a study with men, and what was very important to them was work, was this Hispanic culture that was expressed in public. That was so important to them. The way they were treated at work, the way that their families were important to them, but it was more of a social identity factor. And for the women, it was, they expressed their Hispanic culture with their relationships, in their personal interactions, and who they took care of at times. And when you looked at a nursing home environment, it didn't let them express that. There was nothing that expressed a Hispanic identity or allowed them to express that in a nursing home, nor did they see that anywhere within a nursing home. In fact, they saw it as the exact opposite of that, as a symbolism of lack of Hispanic culture. So, thank you.
Very nice overview, and I'm sure that there are some questions or comments. We have a little bit of
You did study men. In general, are men more resistant, did you find, for assisted devices than women? Or their attitudes less?
I did not, I did the interviews with them, and I did some measures of disability function and limitation, but I did not go back to them and do the analysis on assistive technology. So I cannot speak to that, and then I can go back and look at that, but I can't right now. But good question. Good question. Yes, sir.
Back in when you do just quantitative study, to be able to get into the attitudes and values. What also strikes me in some of these nursing homes is this lack of sense of purpose that the people that we used to have, and the boredom and loneliness that is well captured, by these. And from going to all these different counties and nursing homes, what do you see that we can, either from personal public policy point of view, that at least improve, I don't want to say quality of life as opposed to quality of care, at least within the domains of loneliness, the boredom, and this just complete lack of sense of purpose that I'm getting from some of these comments in the nursing population?
I think that that's a really good question, because the answer has always been person-centered care. Make it more person-centered. Give them more decision-making skills, and they will be happier if they can control that environment a little bit better. But we aren't getting that data to play out necessarily, and some of the studies that I've seen is not supporting that. And when you talk to people who run nursing homes, they say that that isn't necessarily the best way to care for people, in that when you get to the point of needing nursing home care, sometimes you need fewer choices. That it can be too overwhelming, and you need a more simplified environment. But at the same time, you need something that reminds you of who you are and what your identity is. So it's not about just saying, what do y'all want to do? Let's do anything you want, even though that's really not an option. And then it becomes menial as to what toilet paper to pick out, and that's an insult. So what is the choice that supports identity? And really thinking that through.
Using some Hispanic is problematic,
Oh, sure.
but I mean, just to say, to take away, to take someone out of their family and put them in a nursing home, automatically is doing something to their identity, because so much of identity is based on family.
Right.
So how do you go about providing care in a nursing home for folks who are rooted to some other place?
Mm-hmm.
And not letting people visit and that sort of thing? It seems like it's counterproductive. It sounds like that would be hell for them. That would be the absolute last place they'd ever want to be.
Mm-hmm. If you are thinking that the identity is in the family, are you creating an atmosphere of family there? Do you have pictures of family in that environment? Do you have something that reminds them that their family did love them? Do you have a reminder for people whose memory has stopped earlier in a time point that your daughter called at this time? You haven't not heard from her in a year or two. She called at this time, and here's a picture of her. So there are times when people need nursing homes, but are we reminding them that their identity exists somewhere? Or are we making a stale environment that's not so bad? It doesn't smell so bad. It's like a hotel. Yes.
I have a question. This is what comes from the description which you were giving, that really the factor of emotional resilience, which means, those folks who are less emotionally resilient, which means they don't have so much, self-esteem. They don't have, when they take the self-esteem from the outside, from the family, from, their culture, okay, who I am. This means I have a disability, immediately I'm somebody else than I was. And, maybe this will flow to this emotional resilience actually being, associated with their earlier life, and the fact that they had long-standing depression, maybe not even treated, will put them more likely to the nursing home than the different attitude of women, say, who will have better emotional resilience for whole their life, and they are not identifying themselves neither with, environment, which means I am not who my environment is, neither my disability. But I don't know if you see the difference between those factors, in emotional resilience and self-esteem source of in those two populations.
I would say that all of us would experience some level of threat to our self-esteem and to our degree of resilience in the face of that degree of loss, confusion, and loss of home, family. I think it can be more situational, or it can be something that gets out of control and long-term if we're not careful, and we don't. And I think that's where, as professionals, we can intervene and make a difference in some of these ladies' lives if we do step in and say, there are other ways to support this, more productive ways. Of course, some of us have stronger internal resilience stepping into situations, but I think that the way we approach can really make a difference. But I would agree with you.
UTMB Health, working together to work wonders.